standard medical wound assessments fail for a specific reason. Multidisciplinary care teams lack a shared, objective clinical language. This illustration captures the core problem. When clinicians rely on subjective observational adjectives, saying a wound looks a bit red or seems to be getting better, they create a fractured and highly unreliable medical picture of the patient's actual condition. To correct this, the assessment process requires an immediate transition away from casual adjectives to hard quantitative. We have to rely on strict dimensional measurements and exact exudate volumes. An accurate wound assessment is not a passive observation. It is an active data extraction protocol designed to precisely classify the damage. Specifically, the protocol extracts data to classify wounds across 3 distinct targets: etiology, general appearance, and localized characteristics. Without this standardized syntax, clinicians possess no reliable mathematical mechanism to track whether a wound is progressing toward healing or quietly deteriorating. The solution to this communication breakdown is the HEIDI framework. This framework acts as a step-by-step operational algorithm rather than a static checklist. It moves strictly through history, examination, investigation, diagnosis, and implementation. The first half of the acronym deals exclusively with gathering raw inputs. History and examination establish the physical and biological baseline. The second half takes those raw inputs and converts them into a medical strategy through investigation, diagnosis, and implementation. Moving in this exact, unyielding sequence prevents clinicians from jumping straight to topical treatments before the underlying systemic causes are properly identified. Executing this algorithm effectively translates subjective visual cues into an objective, actionable medical dataset. Entering the first node, history, we step back from the localized damage. Assessing the total patient history is what establishes the biological baseline for repair. A wound requires significant physiological resources to close. Comorbid conditions like vascular disease or diabetes place hard limits on the body's capacity to deliver oxygen and nutrients to the site. Patient lifestyle factors, ranging from nutrition to mobility, act as additional variables. If left unrecorded, they will severely skew the accuracy of the prognosis. This photograph maps the terminology of a sacrococcygeal wound, moving us into the examination node. First, we extract quantitative size by measuring the longest length and widest width. Second, we calculate relative percentages of granulation tissue, yellow slough, and necrotic tissue. Accurately identifying the precise ratio of these tissues directly dictates the topical interventions required later in the algorithm. The third predictive factor requires measuring and categorizing the volume of exudate, the fluid present within the wound bed. Combining these specific dimensions, the tissue composition and the exudate volume, builds a complete geometric and biological profile of the localized damage. Establishing these 3 quantitative baselines during the examination node is the only scientific method for tracking true tissue deterioration over time. The examination phase does not end at the open cavity. The focus must expand outward to the surrounding skin. Returning to our sacrococcygeal wound photograph, we evaluate the peri-wound. This assessment zone is strictly bound, extending exactly 4 centimeters outward from the wound margin. Evaluating this specific 4 centimeter zone is clinically mandatory to detect unseen outward damage extension beneath the surface layer. Transitioning to the diagnosis node, the data gathered forces us to confront a primary clinical misconception. Not all wounds are biologically capable of complete closure. This table outlines healability, our primary triage filter. A wound is healable if blood supply is adequate and the cause is correctable. A maintenance wound has potential, but systemic issues block healing. A non-healable wound lacks perfusion, making closure biologically impossible. Diagnosing a wound's healability shifts the therapeutic objective from complete closure to stabilization or palliative care. This redirection prevents the clinical failure of attempting to repair tissue that lacks the biological capacity to heal. Moving into the final node, implementation, the comprehensive assessment forces the treatment plan into a dual architecture design. The data demands a split-path logic. One track addresses the systemic cause, while the other simultaneously addresses the local damage. Tracing the etiology path, the classification of the wound dictates immediate medical interventions tailored to the patient's entire biological system. For example, diagnosing an arterial wound mandates evaluating the arterial circulation using a Doppler, whereas identifying a venous wound mandates immediate compression therapy. Tracing the appearance path, the quantitative data gathered during examination dictates the required localized topical management. Focusing exclusively on local topical care while ignoring the systemic etiology guarantees clinical failure. Both tracks require simultaneous management. To guide the local management track, clinicians utilize a specific framework known as the time principle. In this journal abstract, we see the time principle defined: tissue debridement, infection control, moisture balance, and optimal wound edges. T and I connect to examination, triggering debridement and infection control. M and E rely on the peri-wound assessment for moisture and edge optimization. The entire time framework is utterly dependent on the accurate, objective data extracted during the initial HIDE steps. A rigorous, standardized HIDE assessment removes the guesswork. It ensures every clinical intervention is rooted in objective data, producing the most realistic and effective patient outcomes possible.